Hi, Dr. Jacobs. Thank you for joining me here in the Interviews with Clinicians section of the Dutch Brain Olympiad 2022. You're a neurologist. Could you introduce us a bit more into your field of expertise?
Well, good day. Thank you very much. Yeah, I'm a neurologist at the University Medical Center in Groningen. And a neurologist is a physician that treats or diagnoses and treats patients with neurological disease, and that are diseases of the nervous system. So that will be the brain, the spinal cord, and the peripheral nerves, and even the muscles. So it's well, the nervous system is a big organ involving the complete body. And a neurologist sees patients with, well, different diseases. You can think of a headache, about stroke, a hemorrhagic stroke or an ischemic stroke. You can think of Parkinson's disease or Alzheimer's disease. You can think of tumors of the brain or the nervous system. But my expertise is traumatic brain injury or neurotraumatology, and that means that I have specialized myself in treating and diagnosing patients with traumatic injury to the nervous system, so peripheral nerves, spinal cord, but also the brain. That's my most specific area of expertise, traumatic brain injury. And that means that I diagnose and treat patients with injury to the nervous system. So due to an accident like a fall or a car accident or a fall from a bike or a sporting accident.
That being said, could you tell us more about what kind of patients do you see?
I see patients with peripheral nerve injury, and of course, what I said, patients with traumatic brain injury, from the mild forms of traumatic brain injury. In Dutch, we call that hersenschudding, or in English, concussion, to the more severe patients with severe traumatic brain injury that, for instance, have, well, persisting neurological deficit.
And what symptoms do patients with the traumatic brain injury experience, if you could tell us more about that?
Yeah, so if you look at patients with traumatic brain injury, well, you could say there is not one patient with traumatic brain injury. I mean, every patient is, of course, an individual, but also the group with traumatic brain injury is very heterogeneous. So we have patients with rather mild traumatic brain injury. As I said, in Dutch, we call it hersenschudding. In English, it's concussion. You can have a short period of confusion or even loss of consciousness, and then maybe a phase of memory loss or what we call post-traumatic amnesia. And it can be very short, let's say minutes. But because the patient has fallen from his bike or has fallen from the stairs, they will be brought to our emergency department to see if there's any lesion in the skull or in the brain. And in case of a concussion, hersenschudding, most of the time there is no permanent neurological deficit, and we don't see any abnormalities in, for instance, a brain or a head CT scan. But we also have patients with very severe traumatic brain injury, and they present or are presented in coma, for instance. So they have a very severe loss of consciousness, and may even have a severe outside neurological or traumatic injury to the skull or to the skin or to the face, and they are presented with a severe coma and well, other neurological deficits. So there is a broad spectrum from very mild to very severe, and even the very severe patients, 40 to 50% will die within the first 6 months. So it's a broad range, a broad spectrum of traumatic brain injury patients. And if patients survive and they present themselves during follow-up at the outpatient clinic, you can have post-traumatic complaints, and they can be from post-traumatic headache or deficits in concentration or attention, or maybe difficulties with memory, to the very severe patients who have, for instance, a paresis or behavioral problems or very severe cognitive deficit like memory problems or well, it can be all in those kind of cognitive functions. So you can compare it with a patient with Alzheimer's dementia. So that can be that severe.
Okay, and how do you exactly diagnose patients with the traumatic brain injury? Could you tell us more about the essential or important criteria that are being measured when it comes to diagnosis?
Yeah, well, if you look at patients with traumatic brain injury, the diagnosis in that case is rather simple, because the patient has had a trauma. So you know that they have fallen or they've been part in a car accident. So that makes it a little bit more easy than colleagues of mine who have to diagnose a stroke or whatever. So a patient has to have had a trauma. That's where it starts with diagnosing traumatic brain injury. But okay, and then it starts already at the scene of the accident or at our emergency department with, of course, like any doctor will do, taking history. So when a patient is again awake after a short loss of consciousness, you can take a history. What happened? What are you experiencing now? You can do some neurological tests about their memory or about their orientation. But if you have the more severe patients that are in coma at the scene of the accident and during the transport and at our emergency department, of course, I can't ask the patient any questions. Well, I can ask them, but they won't answer. So I have to do a neurological examination. And one of the important aspects of our neurological examination of patients with traumatic brain injury is the Glasgow Coma Scale, which was developed in the 70s of the last century. And with some easy test, you can determine the level of a patient's consciousness. So with a score of 3, the lowest score, a patient has deep coma. And with a score of 15, the patient is fully alert, like we are when we're talking like this. So we can use that to determine the depth of consciousness or loss of consciousness, and we can determine the clinical severity. So when a patient has a Glasgow Coma Scale score of 8 or lower, we call a patient in coma. And we treat the patient differently than when the patient is, of course, has a coma score of 14 or 15 and is fully alert and awake. There's some treatment differences. You can appreciate that. So, and after the neurological examination, most of the time, in most of the patients, we make a head CT scan to look at the skull, but also at the brain tissue to see if there is damage. And most of the time, we look for traumatic hemorrhaging. So that's a reason to do. And we can also use an MRI scan of the brain where we can see, which is more specific for traumatic injury, but we can use it in the acute phase at the emergency department. So we'll be using it in the subacute phase or in the outpatient clinic. So that's some relatively easy, straightforward ways to diagnose a traumatic brain injury. But you have to imagine we also rely on the medical history and what has happened, because for instance a patient with a concussion, a hersenschudding, we don't see any abnormalities in the CT scan and also not in most of the MRI scans. So we really rely on the description from bystanders from the accident or from the patient to make the diagnosis of concussion. So we can't always make the diagnosis with just imaging modalities.
And in the number of patients that you see, could you tell me more about the most common underlying causes of the traumatic brain injury and or the risk factors for developing such an injury?
Yeah, that's of course the important underlying causes is experiencing an injury. So a ball to the head, or fall from the stairs, or fall from the bike. So you have to have a trauma, because otherwise it's not a traumatic brain injury. But that's maybe a little bit too easy. So what we can do, we can look at patients or persons, I would say, before they are patients, persons that are at risk for getting a trauma. So we know, for instance, that male sex gives a high risk for traumatic brain injury. That has especially adolescent males. So at the end of the puberty and the beginning of the adulthood, they have a risk-taking behavior more than females. So the adolescence in male is a high risk for traumatic brain injury. So that's a way to look at it. We also know that there are some age groups that are more vulnerable to fall. For instance, elderly, they might fall more easy from a stair or from their bike. So that's also a group that has a high risk for traumatic brain injury. And of course, children, because they are very vulnerable in traffic, in their own house, they also experience more frequently a traumatic brain injury. And especially in these vulnerable groups, older age and children, the extent of the injury can also be much more higher than, for instance, at patients of 20 or 30 years of age. Of course, if you do a sport, a violent sport like contact sports or karate or boxing, yeah, you're more likely to get injured in your head than when you do swimming. So there are also risk-taking sports, for instance. So I think that's our important risk factors for getting a traumatic brain injury. And most important, one of the other important is use of alcohol. So not the drinking, but when you drink alcohol, your balance is more disturbed. You fall more easily from your bike. We see in drunk patients or in patients that are experience traumatic brain injury in a bar or in a pub, people get more aggressive and try to hit each other in a bar fight. So alcohol is also, a factor. Alcohol use or misuse is a factor for getting traumatic brain injury.
And lastly, could you tell us more about the current treatment options for preventing or treating the progression of traumatic brain injury?
Yeah, I think we first have to start with prevention and even primary prevention. How to prevent traumatic brain injury? Well, most easy way would be to stay in bed and never get out. But that's not possible. You can also look at risk-taking behavior. Do you have to drive your bike down a slope with a high speed, or do you have to do contact sport, fighting sport? Do you have to drink alcohol? But there's another way. I took this with me from my daughter from 8-year-old. If you're riding a horse, you put on a cap. I couldn't bring a real horse. But what I did bring was, if I go skiing, and a lot of the students that are looking at ski, you take a ski helmet with you. So that's also a way to prevent. And the last one I wanted to show, I take off my headset now. So when I go biking, well, not my regular city bike, but when I do high-speed cycling, I put on my own helmet. So a very important way of preventing traumatic brain injury when you do some risk-taking sports or whatever risk-taking behavior is prevent your head with, in this case, a helmet. So I think that's very important. So what we're trying to do now is to get also, for instance, a vulnerable population is the elderly that are using e-bikes, and those e-bikes, the electric bikes, they cycle then at a higher speed. We really want them to also put on a helmet because they tend to fall more easy than younger people, but they also are, their brains and the skull is more vulnerable if they fall from the bike. So please put on a helmet. When you look at treatment, well, it's like like I said, the population of patients is very heterogeneous, and that means also that the treatment is very heterogeneous. In a mild traumatic brain injury and concussion, there is no much treatment. Sometimes we do some observation at our ward, but you have to wait on spontaneous recovery. But if you look at very severe injured patients in coma at our intensive care unit, maybe the neurosurgeon has to operate and take out a hemorrhage, for instance, and we have to treat the raised intracranial pressure due to the damage. So that's the most severe end of the spectrum. But luckily, most of the patients with a concussion, the mild spectrum, they recover completely and spontaneously. So you have to prevent it if you want to do something.
Yeah. Thank you, Dr. Jacobs, for joining me today. And thank you so much for sharing a glimpse of the knowledge needed to understand the traumatic brain injury.
Oh, thank you very much. It's very nice to do.